All right. Hello, everybody. Welcome to the Intellectual and Developmental Disabilities, or IDD, Interest Group webinar brought to you by the National Council for Mental Wellbeing. Thank you for taking the time to join us today. We are happy to have you. In today's webinar, IDD Managed Care, Why You Should Care, we will review the status of managed care for individuals with intellectual and developmental disabilities, or IDD, and intellectual disability and autism, IDA, across the U.S., while also providing context for the IDD and IDA services and the delivery of other services and emerging integration initiatives. As a reminder, there will be a Q&A at the end of today's session. My name is Nicholas Thomas. I'm so thankful to be here today. I'm the Director of Content Marketing for the National Council. I'm also joined by my colleague, Nicole Cadovius, Mental Health First Aid Director at the National Council, as well as a thought leader supporting our IDD and older adults interest groups. Before we get started, I have a few housekeeping notes to share. We are recording this webinar and we'll be sure to share it and the PowerPoint slides with you after the session ends. Please note you are currently in listening mode. You may send us questions at any time during the webinar. To do so, simply type your questions into the Q&A box on the bottom of your screen and send it to the panelists. We may type an answer back to you, address your question live, or respond in the Q&A session at the end of the webinar. We'll answer as many of your questions as time allows. As a reminder, this webinar is brought to you by the IDD Interest Group. The National Council's interest groups are digital communities designed to help individuals advance care for historically underrepresented communities. It's a chance to network with like-minded peers, stay on top of trends and social issues, guide forward-looking discussions, and propose new solutions to pressing problems. As an interest group member, you can attend webinars with subject matter experts like this one, build connections with peers, access exclusive resources, and share your own. We currently have 7 interest groups and we'll be adding more in the new year. To learn more, contact myself, Nicholas Thomas, at nicholas.t@thenationalcouncil.org, and I will share that email in the chat box momentarily. At this point, my colleague Nicole will introduce our guest speakers.
Thank you so much, Nicholas. Welcome, everyone. I'm so excited for this panel today, and really excited because we're going to have both family and provider perspective, and that is a really unique place to be. So thank you for taking the time to be here. And I just want to welcome Monica Oss, the founder and CEO of Open Minds, an award-winning informative source, executive education provider of business solutions, a firm specializing in various sectors of health and human service industry, serving complex consumers. And Dr. Fady Sahhar, president of XtraGlobex, Inc., a company that he founded in 2001 to assist healthcare providers, accountable care organizations, and service organizations in building an exceptional and sustainable competitive advantage. And then we will be joined shortly by Dr. Richard Edley. He is part of the National Council Board and my colleague in creating all of these IDD group webinars and blogs and anything that this group may be interested in hearing more about. So I'm grateful for him for putting this esteemed panel together. He is also the CEO of Rehabilitation and Community Providers Association in Pennsylvania, which represents the providers of health and human services committed to effective, efficient, and high quality care. Again, Nicole Cadovius, and really excited to welcome you all here today. And I'm going to pass the baton along to Monica shortly. Please use the chat box, warm it up, let us know where you're from, what you'd like to hear more about. We also will have the Q&A section open at this time. Feel free to ask questions throughout. I'll be moderating the panel today, and when appropriate, stopping to ask the question, or we can save some to the end as well. And so without further ado, Monica.
Great. Well, thank you, Nicole. I am really thrilled to be here and kind of be the I would say the lead-off batter in what I hope will be a really informative session for everyone who's here. If you want to move to my first slide, what I'd like to do to kick this off is I put together a little bit of background in terms of the landscape. I think it's important when we're talking about kind of any topic, but particularly one that's as complicated as this, to kind of get a level set for the entire audience. So those of you who already know these stats, you'll have to bear with me as we kind of bring everyone up to speed. So go ahead to the next slide. One more. There we go. So just a little bit of level setting. There are about, to give you an idea of market, there are about 7 million people in the US who have an IDD disorder. It's about 2% of the population. When you compare that to the kind of autism prevalence, and I'll talk a little bit about the overlap in a minute, that is about 2.3% of the population, so a similar but slightly larger number. When we think about financing, if you move to the next slide, kind of understanding how all of this fits together is a critical piece. We have about a 35% overlap when we look at consumers with autism who are considered to have an intellectual disability. So while there is a significant overlap, there are some obviously unique both population demographics and with that kind of system design issues that come up when particularly states or any kind of payer are looking for that full service approach. Nope, you can go ahead. I wanted to kind of call out kind of when you read statistics about the markets, the behavioral health services market, which is about 7% of US healthcare spending, includes treatment for mental health, treatment for addiction, and autism treatment is actually included in that bucket. So we have about 18.5 million people who use behavioral health services in any given year. This is kind of, how we define that 7% of total spend that is spent on behavioral health. Now, if you move to the next slide, we can take a look at long-term care. There are about half as many people right now who use long-term services and supports. And that does include consumers with IDD. This also, from a spending perspective, long-term services and supports make up about another 7% of total US healthcare spending. So the combination of behavioral health and LTSS spending, you're looking at about 15% of total spend is really designated for these services. Now, if you move ahead, just a couple kind of interesting budget statistics. So I just got just updated for this presentation, the new statistics for this that are most available. We've spent about $445 billion each year on long-term services and supports. In terms of overall spend, and I'll talk a little bit about public spending in a minute, LTSS spending increased an average of 9% a year over the most recently available 5-year period, which is 2015 to 2020. It is increasing at about twice the rate of the kind of overall healthcare spend. So it gives you kind of a framework for policy. Medicaid remains the largest payer for LTSS services, and it kind of dwarfs Medicare, out-of-pocket, and private insurance as a payer for long-term services and supports. And when we look at the breakdown of that spending, about 55% is spent on home and community-based settings, about 35% on institutional spending. So this is a kind of the current roadmap or framework for spending if you're a policy person, a state Medicaid director, someone who's looking at kind of health plan design. Now, if you move
Monica,
yeah.
Sorry, may I just ask, in the definition of long-term LTSS, does that include nursing home and assisted living for the aging population?
Yes, yeah, all of that is included in that long-term services and supports payment bucket.
Thank you so much.
Mm-hmm. And on to the next, which brings us to, if we look at just the subset of public spending on IDD, which is going to be a lot of the focus of the discussion today by Fady and Richard, what we see is that, this steady increase over the past 15 years in terms of public spending. This includes federal, state, and local spending for IDD consumers specifically. What's even more interesting, if you look at the next slide, is is looking at the healthcare cost comparisons for individuals with co-occurring autism and IDD. And these, as we start to think about these statistics, this is really a key piece of kind of state policy when states are looking at should they, move Medicaid to some form of managed care for these consumers. And it's very heavily intertwined, the policy decisions with spending. The black bar shows the average annual spending for someone who has a co-occurring autism and intellectual disability. The light green bar is autism alone, and the far right bar, the darker green bar, is the average for the general population. I did not have current data on the IDD alone population and increased spending. What is the most recent data that we had showed that someone with an intellectual and developmental disability actually spends more than the average from 0 to 65 years of age. But when they hit 65 or older, their healthcare spending actually dropped. And it's kind of the only available data. It's it's a little bit questionable, and we're still trying to dig through and see if we can find a better snapshot of spending and healthcare cost comparisons for those groups. Now, if you move ahead, because I want to pivot into kind of some of the healthcare cost issues, but I think from a state policy perspective, particularly Medicaid, state Medicaid directors, there's growing competition for long-term services and supports resources, and they really fall in three categories. We certainly have an aging demographic, and with an aging population, a population that's in need of more supports with activities for daily living, will put increasing pressure on Medicaid budgets for their support. What concerns me the most, and I've written quite a bit about this, is the increase in the prevalence of multiple chronic conditions and related disabilities in the population under 65. And we have seen this number continue to grow, I think, from a public policy perspective at a fairly alarming rate. We're still waiting to get the kind of post-COVID numbers in terms of the COVID effect on kind of long-term disability in the under 65 population. And then we have had a kind of market increase in the incidence of Alzheimer's and dementias. What is the last CDC numbers showed a slight decrease in overall prevalence of Alzheimer's and dementia. We're still trying to untangle kind of exactly what that means in terms of long-term trend. But from a state, Medicaid director policy, all of these populations, including the populations with intellectual and developmental disabilities, need to be served by a common long-term services and support budget. So there's a lot of, I would say a lot of planning going on at the state level about the best policies for each of these populations and how they fit together with an overall LTSS strategy at the state level. Now, if you move ahead, we can see kind of what are the factors that we see kind of shaping the field. And here I want to talk a bit more from the two customer groups that we work with the most. That is the service provider organizations who are providing LTSS supports to consumers with IDD, and then state and county government agencies who are developing policy, practice, and reimbursement for those services. And there are really four things that I think are shaping strategy and developments in the market. One of them is we have certainly seen a market consolidation among service provider organizations serving the IDD population. This really has nothing to do with managed care. I think it's largely the result of reimbursement rates that frankly haven't been updated in 20 years. And what you're seeing is continual cost pressure on traditional service provider organizations who are kind of looking at, you know, whether or not they have a sustainable business model going forward, again, with or without considering managed care. There are big developments in assistive technology. I think these technologies and how they are adopted, how they are reimbursed, have the potential to markedly change the service delivery system. But I would argue that the financing and reimbursement system needs to change to make the technologies both widely available and cost effective. We have state budget issues, and then we also have, you know, the topic of the day and the whole issue of the application of managed care types of models and principles to managing long-term services and support systems. Where we are right now, and I'll just close with a couple quick overview slides before I turn it over to Fady. If you move to the next slide. This is the most current numbers that we have about the consumers receiving services through Medicaid managed care. So this is specific to Medicaid members. What's interesting is about half of consumers eligible for Medicaid who have an intellectual and developmental disability are getting their medical benefits through some type of Medicaid managed care. That number, you know, our estimate, so that's about almost half, 46%. The percentage of consumers who are getting their long-term services and supports through some kind of managed care model is obviously far smaller, about 15% of the population. So it's in, you know, I like to think that if you're an organization serving someone with an IDD, you're going to either be working directly with managed care organizations or indirectly in terms of the delivery of people's healthcare services. And last but not least, just kind of the overview of where we are now. If you go to my last slide, this is kind of the roadmap when we think about managed long-term services and supports. There are 6 states that have managed LTSS that does not include IDD. There are another 10 states that have statewide or more scalable system-wide initiatives. And then there are 8 states that have varying types of IDD demonstration projects. And to kind of take this to the next level and talk about some of these states and lessons learned, I'm going to turn it over to Fady.
Thank you. So I'm going to, if you'll take me to the next slide, please. I'm going to walk you through some of the experiences that we've observed in the past 5 years in terms of what's going on with IDD managed care. Our group analyzes this on a regular basis, and as we look at the 10 states where there are statewide programs today, you see that they're the same ones that Monica just talked about, but they are really unique in very different ways. And I added 2 states to the bottom here, Pennsylvania and Oklahoma, specifically for 2 reasons. One is Pennsylvania has a very small and unique, fully integrated autism and physical health program that is that's been around for about 4 or 5 years. It's doing well, and it's already every time somebody looks at it from outside, they see it as an ideal model for managed care to be in. It's a single door. You receive all your services from a single provider. That it looks a lot like some of the PACE or LIFE programs that you may be familiar to with for the aging. But so it operates effectively as a fully integrated managed care program. This week, I'm sorry, can you stay with for the prior slide for a second? This week, as a matter of fact, an exciting, for the first time, we have a new state that released an RFP for a statewide program. That's Oklahoma. And I want to seed an idea here that I'm going to talk about as we go through the next few slides. And that is the inclusion of provider-led organizations, where traditionally we see managed care as a relationship between a payer whether it's MCO or a state entity, we have the providers who are on the boots on the ground delivering the services. We're seeing across the state, across a number of states, the introduction of provider-led organizations, entities that are specifically formed for the purpose of contracting with managed care organizations or with payers directly as the state. Full disclosure, I happen to run one of those companies in Pennsylvania. I'm not going to distract you with it, but if you want more details, please feel free to reach out to me. Before we leave this slide, I want to tell you that these 10 states, as they've been running their programs for some as long as 15 years in Arizona, and some as little as 2 or 3 years in Iowa, are each very unique in the way they deliver their services. And a friend of mine, when they introduced me to managed care, reminded me that you've seen one managed care plan, you've seen one managed care plan. So if you please go to the next slide, we're all watching very carefully what's going on in California. California, and in the last, since the beginning of 2022, rolled out a new program called CalAIM that really integrates services for consumers, including their physical health, their behavioral health, and their LTSS services. So CalAIM is a model that is now being watched very carefully, because it allows us to monitor the total cost of care in ways in a large enough population that we have historically not been able to monitor as carefully. So we find it pretty exciting that it's being done on a very broad scale. And CalAIM, I'm sure there's out of 157 people on this call, I hope we have a few people from California. So please, as we get to the Q&A, chime in and give us your perspective, see if we can gain from what your most recent experiences are. Can we go to the next slide, please? So one of the things about IDD managed care in particular is that in some states, we're learning to do IDD managed care. Just to step back, managed care came from a world of physical health, where the providers were at the hospitals and healthcare systems were used to dealing with episodic events. People went in, they got a treatment, and they were released. We monitored them to make sure they don't go back into the hospital or into the institution where they're receiving care. A lot of what we deal with LTSS and IDD is our consumers are going to be with us for the rest of their life. And because of the improving healthcare conditions in our country, people are living longer. So to the point, so in many states where you'll see IDD populations being carved out, individuals age into the more traditional managed care waivers. And I was on a call this morning with one of the state Medicaid directors, was saying, well, I know they're becoming part of my aging waivers, and these individuals are becoming an integral part of who we have to serve at age 70 and 80. And mom and dad are no longer able to support them. So states like Kansas and Iowa went through a very tough learning experience. Iowa, for example, in their rollout of this program, went statewide, and they hired external MCOs, for-profit MCOs, to manage the process. 2 of them ended up pulling out of the state within 18 months. So it's, the conditions that the state creates for the rollout of managed care IDD need to be much more carefully considered than what happens when we roll out a physical health managed care, or even behavioral health or aging waiver type of LTSS services. Kansas literally stopped the program and relaunched it. So, states are observing that this is not a turnkey system. There isn't a book that's been written about the best way to run IDD. And I know I had a number of colleagues who participated in national reviews of various programs, and we couldn't come up with a single best answer. So let's go to the next one. So see if I can give you some dimensions of what are some of the considerations as states go into it, and they decide how to launch an IDD managed care plan. The first one is what populations are carved in or carved out. We have because of the level of acuity that our consumers have across the board, we don't necessarily have a clear cutoff of who should be included and who should not. And the states will make choices about that. For example, in Tennessee, there was a very big push for if you have severe behavioral health needs, then you would be eligible to receive residential services. But if you didn't, then you would only be able to receive community-based services. So, those type of considerations, as some of you are on this call that are wondering what's going to happen in my state, who's going to be included in this program. And you find that because of the cognitive disability umbrella that sometimes we put IDD in, we end up grouping individuals with TBI and other brain injury situations, as well as very classic developmental disabilities. We also have a challenge in the IDD world, and specifically that so many of our services have historically been delivered in residential setting, small group homes and ICFs. And so when you're looking at a movement to managed care, because of the budget considerations that you have to deal with, you can't just say, well, I'm going to move everybody into the community as you would with, for example, the aging population. So there isn't that flexibility for real rebalancing, because as my friend Carol reminds me, that this is people's home. This is where they live. We can't just say we're displacing you and moving you into, some other residential setting. We also find that because of the where human services are delivered, there's substantial needs differences between highly urbanized area, like, I live in the Philadelphia region. And so the difference between the needs in Philadelphia versus Elk County, PA, are going to be very substantial. And so as states are considering different plans, it's difficult for you to consider that you can't just do one cookie cutter for everybody. Thanks, Carol. And you find that so many of our states that are doing IDD as IDD managed care, as Monica shared with you, some of them will do pilots and learn from their own mistakes and refine the program before they roll out very broadly. But that is not necessarily the case in every state. Many states are in a hurry sometimes to rip off the Band-Aid and get there and fix it as they go. So we need to keep in mind that, especially if you are involved in a state that's reevaluating what they're doing with their IDD programs, that you have the opportunity to become a voice that shapes the design. Program design in IDD managed care is very challenging, and I would urge you to get involved in it. Two other very critical dimensions that you need to take into account is the level of integration of physical health. And we have, not all states offer fully integrated programs. and the savings associated with keeping individuals healthy and in the community when they have an IDD diagnosis usually ensue back to their physical health plan. So, by keeping individuals from being admitted to hospitals and ERs and skilled nursing facilities, we are saving money on the physical health side. So the challenge for IDD managed care is that double whammy of we cannot rebalance it very easily, but we also, whenever we do a good job, the savings ensue to somebody else. So how do we over time channel the funding to the right places where the providers are actually delivering the savings to the system as a whole? The last key element I want you to think about is the type of managing entities. Who actually administers these programs? And we see a very broad diversity of who runs these programs. Primarily, you have the more traditional for-profit MCOs, folks like United Healthcare and Centene, who do really good work. You also have many states that, like California today, has put, in addition to the MCOs, they put the counties, the local counties, in charge of managing these programs. And across the country, you find a diversity of participation of management entities. And I'm going to go back to that idea of what happens to the providers. The boots on the ground providers are now becoming increasingly an element that people involve in the design of their managed care programs, not only as recipients of pay, but as an integral part of the managed care system. The leaders, and I'm going to share with you the case study from North Carolina and Arkansas, and now in Oklahoma, we are seeing that there's a growth of that. I'm very excited because yesterday, thank you, Monica, for sharing it in your morning newsletter. New York announced that they are looking at their IDD managed care. And one of the integral elements they've baked in is that they want to have provider-led organizations be part of the solution. They don't want to just hand it off to an MCO or a managed long-term care company organization. Can we go to the next slide, please? So providers, in that sense, have a range of roles that you can play. And so as a provider, you can be just a service provider and a stakeholder, but we're seeing, again, a growing level of interest in providers becoming partners. There's an MCO out of Ohio that does a very nice job of, as they gain ground in new states, they bring a group of providers with them and they help them grow. And as I just said, we are seeing providers becoming managed care organizations. So for a group of you here who are observing what is going on across the landscape, being engaged in this process as your state considers its current waivers, amendments, and updates, but also as your state that considers rolling out IDD managed care for the first time. Next slide, please. A very unique item in managed care IDD is who actually does the case management. And case management, whether care coordination, service coordination, it's many configurations, are usually is where the purse strings lie, right? That's who determines what the person-centered service plans are going to look like. And so traditionally, when the MCO is being contracted with the state, they're the ones who are taking on the risk. And we find them that they usually embed the managed care case management activity into the MCO's role. But that is not the only way it's happened. In a number of states, we find that the service case management, service coordination is being outsourced. And some of the leaders in that space you find are not IDD providers. They tend to be the AAAs and the Centers for Independent Living, while even though they're not specialists in this area of service, those kind of service coordination entities are being the ones chosen whenever the state carves out in their design who does the work. You also find states like Tennessee who have opted to keep case management as a state activity. And so New Jersey does the same thing, where it's like the people who develop the service plan are employees of the state working in tandem with the MCOs. So we're finding in a number of states that the hybrid models are starting to emerge, and we can, you as a provider, I assume most of you on this call are providers, as a provider, you have an interest in knowing how the case management is going to happen, not only just from a financial standpoint, but because of the many relationships. And I hope that you guys will invite us back to, we can have a whole discussion about case management in IDD for an hour if they'll allow us to. Next slide, please. So the last major component before we dive into the two specific case studies is value-based payments. Managed care in its structure is designed to improve quality while reducing costs. And so in the IDD space, where people are not going to get better, they're with us for a lifetime, value-based payments are particularly difficult to implement. And so managed care organizations are looking at how do we enlarge the risk pool so that we can apply value-based payments. Monica invited me about 7 years ago now to make one of my first presentations on value-based payment at the conference down in New Orleans. Great conference, by the way. And at the time we were grappling with the definition of value-based payments in the human services space outside behavioral health. So that's still continuing to happen. Next slide, please. Obviously, because of what populations are included in the definition of managed care, you find that managing the service offerings, there are many states that will carve out residential services. There are states like Tennessee who have made employment services the primary focus of how IDD services are being delivered. Next slide, please. Let me tell you about North Carolina. Next slide, please. So North Carolina was very methodical in its rollout of its managed care program. It actually ended up with about a 2.5-year delay in its rollout. They did roll out a statewide implementation, but they carved it out into 13, 14 different regions. And they were a leader in the creation and implementation of local management entities. And local management entities are partnerships, they're regulatory required partnerships between a traditional MCO and a group of providers in the region who take on the collective risk of delivering these services. And they're designed in a very nice way because the traditional case management entities continue to exist. They respond directly to the regional diversity, and because the health plans are involved in it, they also are able to provide a very high level of integrated care. So in case you wonder, I think that this is one of the most impressive models that we can watch in action as it's being implemented. And but it's young. It's only a couple of years old. So in action. So we're watching it very carefully. Next, please. Let me tell you about Tennessee, because I know I'm way over my time. Sorry. The Tennessee program is a very progressive program. It's one of the ones, but it's also is able to deal with a much smaller population. For those of us who operate in, Pennsylvania and New York and New Jersey, we're used to these large numbers. Tennessee has a very manageable size population that they serve. They're able to separate it into population health groups, and they've recognized the levels of acuity of the consumers that they serve so that they can direct them to different service providers. And Tennessee is one of the first states to make employment a key building block for their IDD managed care services. They do use the state employees for their case management. And for those of us who work closely with Tennessee, the 10 Care group is very involved, and very little happens without them really checking what's going on. And finally, they have a very active provider community, which allows them to really create a balance between, a very nice three-legged stool between the state being active, a highly qualified group of managed care organizations, and an active provider community. Next slide, please. So, Richard, are you here? Can I turn it over to you?
Yeah, I managed to get here. Thank you, Fady. And I
Excellent.
apologize. Nicole, I don't know if you mentioned at the beginning that I'm going to be late to our own presentation. Thank you.
Thank you for being here.
Yes, and I don't know if you did much of an introduction, but I know a lot of people at the National Council. I'm Richard Edley, President and CEO of RCPA here in Pennsylvania, representing over 360 agencies and systems across human services, including intellectual and developmental disabilities. And again, I apologize. We have a new governor, which is going to be part of this presentation. When you have a new administration, things like managed care and IDD become very important, because you never know when the new governor coming in and the new administration will say, well, what is this unmanaged piece over here where we're spending billions? And so I was asked to serve on the transition team for human services, and that's where I was just now at one of the meetings. If you could go to the next slide. Wanted to just hit a few basic concepts, and I apologize again if Monica or Fady covered some of this, but why are we even talking about managed care and IDD? And those are the kinds of questions that a new administration asks. And obviously, the first is you always want to have a quality aspect to it, but Pennsylvania is a lot like other states where we also have a really significant issue in terms of the wait list. And the hope is somehow managed care will drive enough savings to begin chipping away at it. In Pennsylvania, we have over 13,000 people on the wait list, over 5,000 on what they call the emergency wait list, which is a pretty incredible situation. And actually that number is skewed low for two reasons. The way it works here is that if you have autism as your primary diagnosis and you're under age 21, you're handled in the managed behavioral health system. With managed care organizations and so forth. You hit age 21, you no longer get any school services. The community services are gone because you're not, they're all built around 0 to 21. You have nothing. So what a lot of families end up doing, particularly with those with more serious and profound autism, is flip over and get an ID diagnosis, intellectual disabilities, so you can go into that system. So what I pointed out is, so you have 13,000 on the wait list. Every day we're adding more people who are on the other system flipping over to this wait list. So it's a problem. And then finally, you have to look at stabilizing the costs and expenditures. Here we're spending about $3.5 billion, and the wait list alone would probably be another $1.5 billion. So it's a big issue. And notice I said stabilize costs. We always have to guard against anyone who's out there saying we need to decrease cost or decrease cost per person. And that can be a very dangerous situation. The other thing as providers, we're always debating is how much do we want to even raise this issue of managed care and IDD? because, there's a lot of concern, and I'll get into that, about what if some national player who has no experience in IDD but has managed care experience comes in and starts managing this program. On the other hand, not acknowledging this and not having discussion and keeping our heads in the sand isn't going to help anyone. It just means something will happen and we won't even have a place at the table. Go to the next slide. So one of the things is and Fady touched on some of this when I joined. I heard him talking about this when it was, does it include residential? Does it include employment? What about supports coordination? So there's a lot of different variables in terms of program design. I mean, what population is it actually covering? Is it just IDD? Is it just autism and so forth? The other thing is, does it include physical disabilities and behavioral health? Because when you start to think about, well, where will some of the savings come from? If there's going to be any savings that could be reinvested into the program, well, a lot of people point out that it might be in the physical health side. And so, what's included is important. What types of providers and services? In Pennsylvania, we have a very large group of supports coordination organizations doing, the case management with this population. Almost all of them are members of RCPA. And to give you an example, we spoke to one national multi-billion-dollar health plan who's thinking of coming into Pennsylvania around these services. First thing they said to us was, now, of course, we're going to get rid of supports coordination and do it ourselves as an administrative service, for which I had to remind them we represent those providers you just said that you'd be eliminating. And then finally, I'm talking about pilots, a full program, and so forth. And I'm going to talk in a minute about a provider-based solution, which again, Fady was touching on. Bilateral programs become very important because if it's a full statewide program covering this entire population as listed here, all services, all levels of care, well, now you're talking about billions of dollars. Might be hard for a provider-owned based solution to just jump in and get all of the capital needed to do something like that. Where if it's a smaller pilot or provider-driven program, there's a better chance. Next slide. In addition, in terms of the program design, often in these solutions, the high risk populations either get carved out or even forgotten. With all and we gave a presentation for National Council not that long ago on severe and profound autism, and with the rush for home and community-based services and community participation and employment and education, all these things which are wonderful for a disabled population. What about those with serious medical and behavioral complications? How are they into this mix? The other thing is with other managed care programs, like we have a several-year-old program now in managed long-term services and supports. Well, there it's not easy, but you could see where you could say, let's decrease admissions to nursing homes. Let's even get people in nursing homes back out and back home and do the rebalancing between residential and non-residential. Well, in IDD, as you all know, it's a little different. The residential services are not nursing homes, it's their homes. So to say that we're going to take people out, one managed care company said, well, we're going to remove people from those residences and get them in community-based services, forgetting the fact that their residence is in the community. That is their community-based services. So it's a little bit more tricky, and certainly the advocates in this area have a lot more to say about what are you doing here in terms of not allowing my adult child to have access to these services. Really, one of the reasons 8-9 years ago, we were convinced Pennsylvania would go to managed care and IDD. I'm also convinced one of the reasons they didn't was they realized in looking at the landscape, the advocates and the parents and so forth in IDD are a lot more difficult even to deal with than some in the long-term services and supports. And I've already mentioned the whole issue with the wait list. And where do you get the funding from them? Clearly not just from savings. One past director of the Office of Developmental Programs said, we should go to managed care, pay them the amount we're spending right now, and tell them they have to cover the wait list. So in essence, you'd be saying, I know managed care companies do a lot of crazy things and will run for the money, but even the most risky managed care company isn't going to say, all right, give me $3.5 billion and I'll come up with the other $1.5 billion. So that can't be the answer to the program either. Next slide, please. So every state's different, but we have a lot of interested parties here. We have all the various state departments that are involved, like the Office of Developmental Programs. We are a very county-based system in Pennsylvania, so all the counties have a lot to say, and the counties are intimately involved in the behavioral health program, which is with the behavioral health managed care organizations. You have physical health managed care organizations, the LTS managed care organizations, all of these groups feel like, sure, just roll IDD into our program. And the reason that's dangerous, as I'm sure you heard in the earlier presentations, not a lot of these companies have any experience in IDD. People have probably heard me, if you've heard me speak before, say that this is many years ago, I was talking to one large billion-dollar physical health plan presenting on IDD managed care. And the person stopped me and said, slow down, what is IDD? So I had to define IDD. But then when I got to the billions being spent, the next statement was, we need to be in that space. So the physical health plan is desperate to get the business, didn't know what IDD stood for, and that's a problem. Obviously, providers have a large stake in this, and I already mentioned a lot of stakeholders, a lot of advocates, really very concerned about what might happen, and there's certainly always consulting firms around. What it also means in Pennsylvania, and probably in a lot of other states that went through an election cycle, is with a new administration coming in, there's going to be a lot of lobbying and a lot of people pushing and pushing for a solution here and saying they are the solution, which again, going back to my statement about providers shouldn't be acting like it's not going to happen and sort of hide from it. Better that we be at the table pushing for something and talking about other states and other things that have worked, things to guard against, than to just sort of see how it plays out. The next slide, please. Okay, a couple more things about the provider. You can go to the next slide, solution. In Pennsylvania, we did build a provider-based solution. Now, we were a little ahead of ourselves because we thought managed care and IDD would be coming any minute now. And I'm on the board of that company. Fady's the CEO, and I don't know if you had a chance to talk about that, but it's Prevent-A-Care, and it's doing a lot of work in long-term living, doing some work in behavioral health, but it was really originally built for IDD managed care. And I always remind providers, and I've been asked in other states about building a provider solution, you have to sort of check off these three boxes. First of all, just assuming since we're the providers, we should get the business, we should be managing this. Well, then you got to put in some work. Do you have the model in place? How is it going to improve services? How is it going to manage costs? So we've spent a lot of time developing white papers and having meetings and supports coordinators meeting, residential providers meeting, employment providers, really saying that under a managed care model, how might we do things differently? So we can't just assume we have the solution. Someone's going to ask us, well, what is that solution? So we have to have our act together. The second, depending, I mentioned the whole thing about programs versus a pilot, is that, if it's a larger pilot or a program, we have to have some real serious capitalization potentially in place. And many of you know from other presentations I've given that the old association, starting back in the 90s, did own and operate a managed care company that was very successful. Ultimately, we sold it. I ran it for many years. But we had to come up with millions and millions in capitalization and go through lots of hurdles of getting financial backers, licenses, bonds, letters of credit, loans. And that was back when we needed to come up with like $100 million in risk. A little different when you're talking 500 million, 800 million, $1 billion. So financially, what's the model and how are you going to have that checked? And finally, and this is critical, is will it sell? We could have the best model, line up all the finances, we're ready to go. But if the state says, yeah, we're not going to really do a provider-based model, well, you're dead. So a lot of what we do is education and lobbying to make sure that the administration, the legislators aren't scared of that it can make sense, that providers can be part of a solution or the solution. And, does this whole thing best position association members? Beyond the scope of today, but I think that to really be successful as a provider-based solution, you also can't be afraid of risk. There is a lot of money involved. And I know there's been some places that have put in models where they say, well, we want to manage it, but for the first 3 years, we're not going to take any risk. So you're telling the state to buy off in a program that may spend 50% more than they're spending now. And then you'll start figuring out how to manage costs. That's just not going to sell. And you certainly won't sell with managed care organizations. And I assume, Nicole, you're tracking some of these questions, but I did see the one that are MCOs on the line or not, which I should always ask that before I start talking. But it really doesn't matter. It's the same thing I've told managed care organizations. If you go to the next slide, we just want, as providers and associations, as Preventacare, a meaningful seat at the table. If it's a managed care model, that's okay. In fact, all of the managed care organizations in Pennsylvania are members of RCPA. So we actually, it's kind of a unique situation. But just yesterday, I spoke to one of the large plans that really wants to be an IDD managed care. And they know all things equal, we would like to be the driver of this. We'd like to be the owner of it. But if not, we want to be a partner. So again, going back to that whole head in the sand, in the next year, I'm going to be talking to Fady about one more time ought to bring in all the major players, talk to them, see what they're up to, what do they think of the new administration, because I can't predict the future, but I at least want to make sure the providers are positioned as well as possible. And I'm really not anti-MCO at all. I'm just saying that if you go to the next slide, it kind of leads into this. I'm just saying that the traditional things managed care organizations have done don't really work with IDD. So that's really my message. Not, I hate MCOs. I don't. I mean, they're members, they support us, we partner with them. But an IDD, just simply taking that population and rolling into an existing program and thinking it will magically be managed is the wrong solution. So I often will show people this slide and you start to think of, all right, so what worked, say, in behavioral health managed care, since a lot of you are probably behavioral health providers. Things like pre-authorization, utilization management, negotiating fees, admission criteria, readmissions, looking at lengths of stay, all great things, most of which are not applicable to the IDD population. So that's the main message, that there really has to be a much more thorough discussion and understanding of the population. Where might there be efficiencies and savings? How would you do this over the long term and so forth, versus assuming because I did it well in that population, it will somehow be good in this population. And even the MLTSS, the Managed Long-Term Service and Supports Organizations and MCOs, probably a little closer to it because they're at least dealing with a lifespan issue and placements and residential things. But again, as I pointed out, dealing with an aging population in nursing homes is not the same as dealing with a younger population that's in need of potential 24/7 care. It's a different ballgame here. The next slide. So in summary, and then we'll have plenty of time for questions, and then we could look at what other questions came in the chat if we haven't answered it, is as I mentioned, to really cover the operational, financial, and political bases. The main pieces you want to have a seat at the table to really be driving some of these discussion and solutions, and flexibility. Things change. And with this new administration, we're going to spend a lot of time lobbying, a lot of time meeting. We also have an incredible number of new legislators and an entire change in leadership. So things like the leadership in the House and Senate, Human Services and Health and Human Services and Appropriations, all different. So a lot of education and lobbying to make sure they understand providers' seat at the table here. One of the things I point out that if you go back to the 90s, why was our old company successful? Because it took years and years before we got our first big managed Medicaid contract. And what it was is we had a deputy secretary of the Office of Mental Health and Substance Abuse who listened to us and said, I don't think this is a bad solution. I would support it. The world changed. We had a leader in government saying, I think a provider-based solution is fine. And he then went to his staff and said, stop saying this won't work. There's no reason it would. Well, now we could start. Now we still had to sell it. We had to get the business and we had to build the infrastructure and get the finances, but a critical change. Today, I don't know that we have that support, but on January 16th at the inauguration, we might, if we play our cards well. Again, the final point is that last bullet point, that it can't just be managed care that we know. It's managed care is a loose term used here. It's really in this very non-traditional space, how do we begin to manage the cost trend, make sure quality is in place, and address wait lists and so forth. So with that, I think you can go on to the next one. We left time for some questions. And again, Nicole or Fady, I saw you monitoring. Are there questions in the chat box that we?
Well, and I want to use my prerogative as your co-presenter to ask a question. So, you both referenced the demo project in Pennsylvania that you're doing. And Richard, you talked a bit about the need to accept risk, kind of at the get-go. Can you talk a little bit about how the reimbursement model works for that pilot?
So you're talking about the ACAP model.
Mm-hmm.
The ACAP model, which is it's a capitated model that is fully at risk for the individuals within it, for both their autism services as well as their physical health needs.
Okay.
And so the entity has about 200 consumers that are currently in that program, and it's capped at that. They cannot add any more to it. And they have to actually get insurance for cost overruns. So they literally have to go to Lloyd's in London and secure any potential exposure and losses.
So it's a capitated model and they're buying reinsurance sort of for the back end. That makes perfect sense. Thanks.
And Monica, the business I was referring to in the past was really 100% provider risk. We decided that at that time, and it was a different era, managed care companies just didn't want to partner with us. I think we were very threatening and all sorts of reasons. So we decided that we're just going to go for it and we'll build a provider MCO. But that was a bold move because, as I point out, if we got $100 to spend 101, I'd have to sit down with the owner and say, who's got the dollar? I mean, I don't have a bank here. We have to come up with the money. It might be that moving forward, managed care IDD, because of the scope of it and the size, and it's a different era. Now we're in 2022, soon 2023, that a partnership with an MCO makes more sense if it can be built right. So we're not against that. It's just that when you look back, there was a different factors that were pushing us.
Yeah. No,
Thanks, Monica. Let me just expand on that for like in states like Arkansas and North Carolina, where these provider-led models are partnerships between a health plan and a group of local providers. They literally form a new entity that is, for lack of a better term, a joint venture. That's a 51% provider-owned, 49% MCO-owned. And they're based on their own, the way the states regulate it, they will assign the level of risk for the first couple of years of where any losses have to be borne and where reserves have to be maintained. So Arkansas operates their PASS system very differently than North Carolina operates their LME system, and just different regulatory. But to Richard's point earlier, in order for these models to take shape, the state has to take action. So as providers on this call or as health plans on this call, you need to really think about how the state has to initiate the design, because that's who has to go ultimately to CMS to get the FMAP money, without which we cannot operate these programs. So has to be an integral part of what state strategy drives the implementation of managed care in this model.
Thank you so much. What a great presentation. We do have a couple questions. One from a new provider, Kenneth, in the Metro Orlando area. And he's wondering, his non-EMS home paramedicine program now administers COVID vaccines, gathers lab samples, and also does client and home assessments with the support of telehealth. What approach might be most effective in getting Medicaid subcontracts to replace their current grant funding?
You want to jump in there? And I assume when you say Medicaid subcontract, you're talking about contracts with Medicaid plans.
Yeah, I was going to say, I think if it's Florida, you're largely your outreach will be to the Medicaid health plans. And I always think the place to start is to identify who are the health plans in your geography with the largest enrollment, because you might as well start there. and trying to do some initial interviews with them about pain points. What are the things they're having trouble solving, and being able to marry what you're doing with a potential solution to a problem they have, and taking in an unsolicited proposal to do whatever that is. But that has been, for us, that has been probably the best avenue for getting new and innovative contracts with health plans. I don't know, Fady, what do you think?
Well, there's a very interesting model that CMS is promoting now. It's called the REACH ACO. It's an accountable care organization that actually brings providers in the IDD space and creates an accountable care organization with a health plan. And so in that kind of situation, you find that kind of subcontracting and sharing of responsibilities. It's very new. They started rolling out in the middle of 2022. There's about 50 of them across the country. And please read. I put my email in the chat box. If you need, I'd be happy to send you more details on what the REACH ACOs are doing.
And Nicole, before you get something else, the last couple of chats, I opened it up now with Shelley Chandler and Shelley Evans. I hope people are reading that. And that's, as you point out, Shelley Evans, about how the provider investors, how did you come up with capital? That's how we did it with our old company. And that's how we're doing it with our current company, Preventacare. And there's probably 100 models of how providers can capitalize these kinds of companies. What we've chosen historically, and again today, is that it is really based on size of applicable revenue. So if you're a $400 million a year IDD provider and we're developing these models and you want to be an owner, probably should put in a little more than a $10 million IDD provider. But at the same time, we came up with this a little bit convoluted Class A and Class B shares of a for-profit, in part because we wanted to keep everyone at sort of as with a similar voice. So we didn't want one mega provider to put in $1 million and they basically are running the company. We could have done it, probably would have been a better capitalization model, but we wanted all the providers who were sitting around that table saying, feeling like they had a voice, whether it was on the board of directors or as shareholders. So we sort of truncated the amount of voting shares you could buy, and then allowed you could buy an unlimited amount of Class B non-voting shares if you wanted to be a bigger owner, just not a voting owner. And then also we would do it based on your revenue and size. So there's more detail to it, but that was sort of our model in going forward.
Danielle just answered a very interesting question about the capital in the chat box. And that was I was working with one of the plans that launched the PASS in Arkansas. And in Arkansas, the only capital that I'm aware of that the providers had to come up with was sufficient just to organize themselves and have the ability to contract as a partner with the MCO. But some of the big costs associated with organized networks like this are not just capital for being able to secure a contract, but it's also the capital for the data platforms, like being able to access data, having the analytic resources to support it. And unfortunately, what happens, and that was my experience in Arkansas, is you end up relying on your MCO partner during the early years until you get your own water legs, essentially, and start to figure out how to manage a system like that yourself.
And by the way, Danielle weighed in. I wanted to comment on that. Talking about a lot of your capital comes from your insurance partner. Technically speaking, initially in our old company, that's what we did. We had to come up with, no one gave us a break being provider owned. So we had to come up with every bit of reserves that any insurer had to come up with and be licensed and the whole bit. So we actually found an insurer here in Central PA that was willing to back us, front the license and all of the risk-based capital, all of the reserves, and we could operate under them, and amazingly allowed us to do all of the operations. So when the phones rang, we were answering all utilization by paying claims. We had to build a company. They just backed it. kind of, not the easiest insurer partner to find. They were willing to do it because they could then, since the money flowed through them, they were able to count those covered lives as a new business venture to their stockholders, their shareholders. So it allowed us to keep real operational ownership of the whole thing. But then also the other piece of it is we had to indemnify them, and we had to come up with the true cash was $8 million. And the reason for that was they felt that, all right, you guys are crazy enough to run this business, but if you start losing money, that 8 million will give us plenty of time to pull the plug on it, and it's your problem, not theirs. So we really did have to indemnify them. And that was a $6 million joint and several bonds signed by multiple agencies that were members of this, a $1 million letter of credit that was signed by a number of agencies, and one large agency with a significant foundation endowment gave us $1 million. So it was a lot back then. And what I'm saying is that was, when that started in late 90s, now it'd be a lot more money, but that's how we did it then as well.
The other interesting thing to keep in mind as you're looking at these kind of relationships is the evolution of access to data has become so much easier. With, like, we're at Prevent-A-Care, we're experimenting now with using health information exchange data, whereas we used to have to rely on the plans to tell us what's going on in our folks' life outside the care we provided. Now we can just access it on a real-time basis. So, we don't want to go off on a Prevent-A-Care tangent but it's a real opportunity for organizations or providers to organize in a way that allows them to have a meaningful discussion with a health plan, not just as here's your rate, here's what I want you to do, but rather bringing to the conversation your ability to look at whole person care in a meaningful way.
Well, I did have a question for the two of you just about there are 6 states that are doing IDD managed care without a provider-led organization. If you had advice for advocates in those states to, and the health plans, how would you like to see the health plan requirements change for better consumer care? What do you think is missing?
You ask the hard questions.
I've got you here. I'm gonna, get all my questions answered.
The interesting part is that in states, like, I'll give you an example. New York is at a very interesting point right now. They've announced that they want to investigate how provider-led organizations can participate in the next generation of IDD managed care. So, the reality is, in order to be a provider-led organization, the first thing you have to do is become an organization. Yeah. What some of the work that Richard did before I joined the group was, we had to form a corporate entity. We had to have people invest in it and decide what they wanted to do and how they want to go about it. But today, the hardest thing is to convince the plans that you are an equal partner. So what I find is important is for you to learn how the plans operate and what's important to them, but also show them what they don't know. Because as we were saying earlier, today, the #1 gap in IDD managed care nationally is there are no health plans that really know how IDD really works and how they can balance the cost and quality aspects. So, as providers, helping really create that level playing field by being prepared for the conversation, opposed to waiting for the conversation to come to you.
Yeah, I think the key word in all of this, when in this state where there's not provider-led or provider ownership, is how do you get it to a meaningful level? I mean, every plan has a provider advisory board, a consumer advisory, they all have that. And I'm not saying that it's just window dressing, but they're not really driving the business. And it's really, if you can lobby the state to push some of the managed care contracts to have meaningful about whether it's through a percentage of contracting through value-based purchasing, which sort of maybe forces them to say, well, then maybe we ought to work with this provider group, as Fady said, that was just created because we could cover the state with a percentage of value-based payments and so forth. That because on its own, and again, this will sound anti-managed care, but it's not. It's just I understand what they're dealing with. Some of these plans are so big and they're doing so many things and so many initiatives, a lot of money at risk. And long-term service and supports, I made the comment that I could go to a plan and say, here's a proposal, it will save you $1 million a year. And even if they believe it, they'll go, look, we are so overwhelmed. How about we meet next quarter? But
Yeah.
and that's with them believing me. And that didn't even move the needle because it's $1 million. We got other things we're worried about.
Well, when you talk about those plans moving to some kind of value-based arrangement with IDD providers, what's your ideal arrangement?
You want to take a shot at it, Richard? You want me to?
Yeah.
You can take a shot first. I was actually gonna have Monica repeat the question.
Well, the
You-
ideal, like every other value-based program, it needs to evolve. I think that one of the biggest risks that providers can take is to expect that when they're negotiating with an MCO, that they're going to go to the risk-sharing end of value-based.
Mhm.
So my counsel would be, if you're going through that process, that you, first of all, and Monica, you've heard my presentations. I usually end them with get an abacus, learn to count.
No.
Learn to count, so learn to, so that go through a process phase, go through a pay for performance phase, go through a bundled payment phase, and then get to risk sharing. Don't jump to try to get to the end of the race on day one, because there's a lot of, the data is not nearly as clean or as, the experience that Richard had with behavioral health back in the 90s, it seemed to have gone smoothly, right? But I'm sure that there were things that were much more complicated than that. I'd say evolve rather than run.
Okay.
Richard, you want to take a shot at it?
Yeah, well, Fady, you've heard me present on this too. And I agree with everything Fady says, but I also, every once in a while, I'll throw in things like readiness is overrated. And you've heard me say that before. That I hate when I hear MCOs say, well, we would want to move into these relationships. Providers just aren't ready. And I also make the point, well, how many more trainings are we going to have? How many more meetings and how many more things? At some point, got to do something. You got to move from point A to point B. Now, having said that, then I agree with you, Fady, that if it's better for you to do it stepwise and rather than jump to the end point and all those things make sense. But I remember talking to one of the, again, this was in the long-term services area. One of the MCOs, it was probably 2019, said something like, "Oh, we're going to look at that like 2022." And I was thinking, so we're going to wait 3 or 4 years and get into that. Like that's the other end of the continuum we don't want to do.
Do you see the value-based arrangements in IDD as they evolve? I'll use Fady's word here. Do you see them including total cost of care as one of the metrics?
See, I think so. And that was what I meant, but it probably wasn't written as well as it should have been on one of those slides where I put in behavioral health and physical health, because some of the savings, I'll give a really simple example. You're in a residential group home, and at least in Pennsylvania, I know I've talked to providers in other states, anything happens, you got to take the person to the emergency room. And there's more costs and things like that because you have to cover yourself. Well, if you're saying, no, you can do that, but you could do some alternatives like work with companies that are doing telehealth and things like that to avoid those, because you actually could get physical health savings from that would be lost if you're just simply covering the residential group home. And there's just a small example, but I think that if you can include total costs, you can at least start to think creatively of, all right, you're not going to change the cost structure of that group home, but what are some of the ancillary costs, some of the other things that are going on that are sort of wasteful? And then also if you can reduce administrative burden, that's a whole other discussion.
Yeah, I think you're right. I think the there are not a lot of savings, to quote both of you, to come from trying to crunch the long-term services and support spending. I think the big gain is how do you have better health for those consumers, which will reduce ER use and reduce hospitalization, and making sure that the model rewards the provider organizations for participating as a partner in wellness with the consumer.
And I saw a comment here. I actually know Will Wenger, and it's something I thought of earlier, but since you put it in the chat box, it's worth repeating. You don't want to overdo how critical finances are and make it seem like you don't even care about the individual. That's not where any of us are, on the payer side or on the provider side. But it is important to talk about what's the value proposition when approaching an MCO. I mean, you can't just simply say, this is really a great program. Now it's going to double your costs, but it's really great. How many people say, yeah, I had a lot of cash sitting around. That sounds like a good idea. So, it really does have to say, how is it improving quality? Also addressing the cost equation, so forth. So I appreciate that, Will.
And part of the learning curve for providers is really learning about the total cost of care, what it really means, as opposed to just my rates, as well as to learn about those pieces that they can impact. Because as you get into value-based payment, the number one challenge is for you to get attribution for the work that you did.
Yep.
And so you have to go in with, I know where I'm starting from, I know which needle I'm moving, and not to try to do it with all your population, because one of the things about health plans is they don't want one program for everybody you serve. So, figure out whether you're talking about an older group that you can do something specific with, a group with diabetes, a group with congestive heart failure, some kind of other co-occurring situation that you can do something about. And now they can acknowledge that. They can really track it. They can look into their MDS data and parse out those individuals that you serve and reward you for the savings that you achieve.
Now, this will get us off into a whole other conversation, but when you think about cost savings in the IDD population, one of the other more controversial pieces, probably nationwide, but certainly in Pennsylvania, it's a hot item now, is there are a lot of parent advocates out there, the more seriously disabled individuals, who point out that some of the more facility-based programs, I'm not going to use antiquated words like sheltered workshops, but those programs that their adult children are in are really helping them, that some more campus-based programs, farmsteads and things like that are really helping them versus smaller group home and community-based solutions. And those are all more cost effective, and the parents will argue and higher quality for their child's situation. But we all know that the national movement is to close these kinds of programs. So it's a big battleground here in Pennsylvania, and I'm sure in a lot of other states, but at some point that has to be looked at. If you're spending more money and getting a lower quality, potentially, outcome for this subset of the population, that should be looked at. And I, by the way, I should say as a disclaimer, and I say this in all the talks where I get into that, is I'm also the parent of an adult child who's exactly in that situation. So I don't want anyone to think I'm just spouting some intellectual, philosophical viewpoint of something I've read. I mean, I get it where the parents are coming from.
Well, I think, Richard, that issue is only going to be resolved by helping state policy people take a step back in terms of exactly what do we mean when we say value, because it is what is good, what is good for one subset of the population is not good for everyone. And how do you actually measure that? Because I see those arguments about, I was in a state where they were having arguments about the 4-bed or the 8-bed group home, what should be in and what should be out. And it's like, well, what do consumers want, and what are the trade-offs, I think, are the big questions. But the arguments end up being based on I would say factors that aren't always as relevant. I'll put it that way.
Well, Nicole, anything else that we missed out there?
There was a question about capitation rate structure, and if you could talk about it for this population. I don't know if we have time. That seems like another webinar in itself, but if,
It could be a whole
if you
other
can
session.
touch on it.
Well, even earlier on in the chat, and I think Fady, you brought it up, that you know, around quality and so forth. And we're one of the states that insists that every single IDD consumer get a SIS. And I know from being at meetings, that inventory scale to me is one of those flawed things that's used nationwide, and certainly when it's hinged to budgets. And so maybe that'll be something, Nicole, we could talk about another day.
Yeah, that sounds good. I think so. I think between the case management and the SIS, yeah, that'll be interesting. I think we have our series for 23, Richard.
Yeah.
Um,
And then Pam just made a comment, Pam Wise, about choice and the importance of choice. And that's where when I get into arguments with some of the people in the state here, and there was one time where one of the state officials said, well, when it comes to some of these programs, the individuals and families don't understand their choice. And I said, that's a real slippery slope, because now you're saying you're going to make the choice for them, when I thought individual choice was like a cornerstone of the program. But suddenly when it doesn't meet your philosophy, well, the choice wasn't a good one. And so that's a real problem as well.
Yeah, if we had more time, I had transformation questions. These were mine, and also cultural shifts and shifting from these models on what that looks like. So I would love to invite you all back in 23 to continue this conversation, and just really want to thank you for your time today. And for our folks, we had most of our people stay with us for 90 minutes. So this has been fantastic. And we definitely want to hear from you. We are putting a survey up. We want to hear, we are starting to plan, as you heard, for 23, for the rest of 2023 calendar year, and want to hear what topics you'd like to know more about. And so please go ahead in the chat. Nicholas did drop the SurveyMonkey. Let us know what you thought of our presentation today and what you'd like to know more about. And again, thank you, Monica and Fady and Richard, for putting this together. So informative, and absolutely kept the attention for the whole time. So thank you.
Thank you, guys. Happy
last-
holidays.
Yes, happy holidays.
Everyone.
Take care, everyone.
Thank you.
Bye-bye. Thank you.
Bye-bye.